Welcome to Optimal Anesthesia. In this episode, we unravel the complexities of exploratory laparotomy under general anesthesia. We'll delve into the causes of intestinal obstruction, fluid dynamics in bowel obstructions, hemoglobin level drops, anesthesia risks, and the impact on hemodynamics and respiration during laparotomy. Let's dive in. To kick things off, let's unravel the mysteries behind the causes of intestinal obstruction. Picture a patient in severe abdominal distress, and one of the many culprits could be causing the obstruction. These causes can be neatly categorized into various headings. 1. Paralytic ileus or paralytic obstruction. Think of this as a temporary traffic jam in the intestines, often triggered by factors such as postoperative ileus, certain medications, or metabolic imbalances like hypokalemia. These changes in electrolytes can affect the body's acid-base balance and overall physiology. 2. Concentric narrowing or mechanical obstruction. This is like a physical roadblock in your gut. Adhesions, hernias, tumors, strictures, and foreign bodies can all play their part in causing this mechanical obstruction. This can lead to changes in blood gas levels, including alterations in CO2 levels. 3. Kinking and twisting of intestinal loops or volvulus. Imagine your intestines in a tangled mess. Sigmoid volvulus, cecal volvulus, and gastric volvulus can all disrupt the flow, leading to significant metabolic changes. For intussusception, it's like one part of the intestine is telescoping into another. Mostly occurring in the small bowel, especially in children, this condition can result in a cascade of physiological changes. 5. A foreign body. Ever swallowed something you shouldn't have? Ingested foreign objects can obstruct the intestines, leading to both mechanical and metabolic challenges. 6. Pseudo-obstruction or Opelvie syndrome. This one's a bit of a trickster. The colon distends without a physical blockage, often occurring in postoperative or critically ill patients. The metabolic and acid-base changes here can be quite puzzling. Picture your digestive system as a complex engine running smoothly. But when a bowel obstruction occurs, it's like encountering a massive traffic jam on the highway of your intestines. These obstructions can happen in both the small and large intestines, setting off a chain reaction in your body. Let's dissect the story. First in our lineup is metabolic acidosis, featuring lactic acidosis as the star. Think of it as the buildup of toxic exhaust fumes when traffic grinds to a halt on the highway. In your body, that's the accumulation of lactic acid and other waste products. Metabolic acidosis arises because the obstruction impedes blood flow, much like traffic snarls. This metabolic acidosis, fueled by lactic acid, can be a prominent actor in the drama of bowel obstructions. The more the traffic jam, the more the lactic acid. Then, there's respiratory alkalosis, like suddenly revving up your engine when you hit a traffic jam. In this case, your body starts hyperventilating due to the discomfort from the obstruction. Now, let's shift the spotlight to electrolytes, those vital substances that keep your body's electrical system running smoothly. With bowel obstructions, you often see low potassium levels or hypokalemia. It's like your engine running low on fuel. Vomiting and diarrhea are frequent culprits here. Hyponatremia, or low sodium levels, can also occur. It's like your engine overheating and losing coolant fluid on a scorching summer day. Then there's hypochloremia, which means low chloride levels. Think of it as your windshield wipers not working during a rainstorm. But wait, there's more. Some people develop hyperchloremic metabolic acidosis. It's like adding too much salt to your meal. It becomes salty, and you might crave a drink. These imbalances in blood chemistry occur because the obstruction disrupts the normal flow in your intestines. It's like a misstep in a well-choreographed dance. As a result, your body's tissues may not receive enough oxygen, leading to high levels of lactic acid in the blood. It's akin to an orchestra's instruments going out of tune. So, what's the plan when dealing with a bowel obstruction? We need to correct these imbalances. It's like clearing the traffic jam on the highway, addressing the lactic acid buildup, and restoring harmony. We may have to provide fluids, manage electrolytes, and, in some cases, perform surgery to remove the obstacle causing the obstruction. Remember, early intervention and close monitoring are essential for helping patients get back on the road to recovery and restoring the balance in lactic acid levels. We'll explore its impact on the body, understand hemoglobin fluctuations, recognize signs of inflammation, uncover common electrolyte imbalances, and discuss the changes in arterial blood gas analysis. Plus, we'll delve into the investigations essential before undergoing anesthesia. Now, let's peel back the layers of the hemoglobin puzzle and explore how it's affected during intestinal obstruction. Hemoglobin, that vital molecule coursing through your veins, is entrusted with the mission of delivering oxygen to your body's tissues. A dip in hemoglobin levels is like robbing your body of its precious oxygen supply. Multiple culprits are implicated in the case of plummeting hemoglobin levels. Picture this scenario: your intestine is slowly bleeding due to the obstruction, yet it remains hidden. This concealed blood loss can culminate in anemia, resulting in lower hemoglobin levels. To give you a clearer picture, in a normal, healthy individual, hemoglobin levels usually range between 13.8 to 17.2 grams per deciliter (g/dl) for men and 12.1 to 15.1 g/dl for women. However, in cases of intestinal obstruction, hemoglobin values can drop significantly below these normal ranges. Interestingly, in some instances of intestinal obstruction, especially when there's significant fluid loss, you might observe a paradoxical rise in hemoglobin and hematocrit values. This phenomenon is due to hemoconcentration, where the concentration of red blood cells becomes higher in proportion to the reduced blood plasma volume. The obstruction wreaks havoc on your body's ability to absorb vital nutrients like iron, which is the cornerstone of hemoglobin. Over time, this can lead to a drop in hemoglobin levels. Think of frequent vomiting and fluid loss as accomplices. They temporarily elevate your hemoglobin concentration, but don't be deceived, it's merely a facade for the underlying anemia. This rise in hemoglobin and hematocrit levels due to hemoconcentration can be misleading, as it might suggest an increase in hemoglobin. However, it's essential to realize that it primarily reflects the dehydration associated with the obstruction. But the story doesn't end here. More lab detectives are at play, and some of them point to signs of inflammation. Increased CRP levels indicate inflammation or infection, often linked to the underlying cause of the obstruction. An upswing in white blood cell count may signify infection or inflammation, further connected to the root of the obstruction. And now, let's explore the less discussed aspect: common electrolyte imbalances during intestinal obstruction. Vomiting and diarrhea associated with intestinal obstruction can lead to significant potassium loss, which can disrupt various bodily functions, including muscle and heart function. Hyponatremia can occur due to excessive vomiting or diarrhea. Sodium is vital for maintaining fluid balance, and when it's low, it can lead to a range of symptoms, including confusion and muscle cramps. The obstruction can lead to an excess of chloride ions in the blood, causing a form of metabolic acidosis known as hyperchloremic metabolic acidosis. This is characterized by an increase in blood chloride levels and a decrease in bicarbonate levels. Intestinal obstruction can also lead to notable changes in arterial blood gas analysis. The patient may hyperventilate due to pain, anxiety, or metabolic acidosis. This leads to a decrease in the level of carbon dioxide, CO2, in the blood, causing respiratory alkalosis. Prolonged intestinal obstruction can result in metabolic acidosis due to a buildup of acid in the blood. This imbalance can have serious consequences on various organ systems. The kidney function can be affected due to dehydration, leading to elevated creatinine and blood urea nitrogen (BUN) levels. These are indicators of reduced kidney function and can be associated with the severity of the obstruction. Before we conclude, let's talk about the crucial investigations that need to be carried out before undergoing anesthesia for the treatment of intestinal obstruction. Anesthesia is a multifaceted process, and comprehensive assessments are essential for patient safety. Pre-anesthetic evaluation includes a detailed medical history, physical examination, and an assessment of any underlying medical conditions. X-rays, CT scans, or ultrasounds are performed to precisely locate and assess the severity of the obstruction. Electrocardiogram examines the heart's electrical activity and ensure it's stable for anesthesia. Chest X-ray will assess lung function, especially if the patient has respiratory issues. Intestinal obstruction is a multi-layered puzzle, and understanding the changes in arterial blood gas analysis, common electrolyte imbalances, signs of inflammation, as well as the critical pre-anesthetic investigations, can help healthcare professionals diagnose and treat this condition effectively. It ensures that patients are prepared and safe when they undergo anesthesia. Remember, if you or someone you know ever experiences symptoms of intestinal obstruction, such as severe abdominal pain, vomiting, a noticeable drop in hemoglobin levels, signs of inflammation, changes in arterial blood gas analysis, electrolyte imbalances, contrasting hemoglobin values, the rise in hemoglobin and hematocrit due to hemoconcentration, elevated creatinine, blood urea nitrogen, and hyperchloremic metabolic acidosis, seeking medical attention promptly is crucial. Early intervention can be a lifesaver in such cases. Let's talk about the dangers during induction and the measures to prevent them. Intestinal obstruction surgery can be challenging due to the risk of regurgitation and aspiration of gastric contents. Here's what you need to know. Anesthesia team, consider using a rapid sequence induction (RSI) technique. This method minimizes the risk of regurgitation and aspiration during the induction phase. Make sure to apply cricoid pressure until cuff inflation and endotracheal tube placement are confirmed. If you anticipate a difficult intubation, it's essential to be prepared. An awake intubation might be the way to go, as it helps maintain protective laryngeal reflexes. Remember to limit or avoid sedation in order to preserve these reflexes. And don't forget the basics. Keep the patient's head elevated during intubation to reduce the risk of regurgitation, and always be ready for rapid aspiration management. Moving on to the use of succinylcholine and the debate surrounding priming with non-depolarizing neuromuscular blockers. These practices have their own set of pros and cons. Succinylcholine offers a rapid onset for quick intubation. It's an excellent choice when you need to secure the airway promptly. Additionally, the priming technique with non-depolarizing blockers can help achieve earlier intubation. But it's essential to be cautious, as succinylcholine is associated with hyperkalemia. Non-depolarizing blockers may lead to a longer duration of paralysis, and the variability of neuromuscular blockade with priming doses can risk aspiration. The decision whether to remove or leave the nasogastric tube before induction also has its pros and cons. Removing the nasogastric tube can allow for gastric decompression and reduce intragastric pressure, lowering the risk of regurgitation. This can decrease the chances of aspiration. On the flip side, removing the tube doesn't guarantee an empty stomach and may render the lower esophageal sphincter incompetent. Plus, it can interfere with laryngoscopy and intubation. Abdominal surgery, especially laparotomy, is a complex interplay of various factors that affect a patient's hemodynamics and respiratory parameters. Understanding these changes is essential for anesthesiologists to optimize patient care. Let's start by exploring the hemodynamic changes when the abdomen is opened during laparotomy. When the surgeon opens the abdomen, it sets off a chain of reactions. One of the first things you'll notice is hemodynamic instability. Blood pressure can drop, heart rate can increase, or sometimes both. Here's why: surgical stress, the act of creating an incision, manipulating abdominal organs, and dissecting through tissues, triggers a surgical stress response. Stress hormones like adrenaline are released, leading to increased heart rate and blood pressure. Anesthesia can also influence hemodynamics. Inhaled agents and muscle relaxants can cause vasodilation, reducing vascular resistance and blood pressure. Plus, exposure to room temperature can lead to peripheral vasodilation. And don't forget about fluid shifts. Surgical manipulation can cause fluid to accumulate in the peritoneal cavity, creating a third-space fluid shift that decreases circulating blood volume. But our cardiovascular system comes to the rescue. It responds by increasing cardiac output and heart rate, thanks to the release of catecholamines in response to surgical stress. Anesthesiologists often administer intravenous fluids to address the third-space fluid shift, ensuring stability. Now, what happens when it's time to close the abdomen? This phase introduces a new set of hemodynamic changes. As the abdomen is closed, previously compressed and ischemic abdominal organs experience reperfusion. This can release metabolic byproducts like lactic acid into the bloodstream, affecting pH and leading to systemic acidosis. Surgical manipulation can also trigger an inflammatory response, leading to vasodilation and increased vascular permeability, contributing to systemic inflammation. Additionally, postoperative pain and the administration of opioids for pain management can influence hemodynamics. Opioids can depress the respiratory system, leading to hypoventilation and changes in acid-base balance. But maintaining cardiovascular stability and providing adequate pain control are key to stabilizing hemodynamics after closure. Now, let's shift our focus to the respiratory changes that occurred during abdominal surgery. When the abdomen is opened during laparotomy, patients experience increased ventilation. The act of creating an incision and manipulating abdominal organs triggers the respiratory center in the brain, leading to heightened ventilation. But pain can be a concern, which is why anesthesiologists often administer opioids for pain management. However, opioids can lead to respiratory depression, resulting in hypoventilation and increased carbon dioxide levels in the bloodstream. The choice of anesthesia, patient positioning, and exposure to room temperature can also influence respiratory changes. Anesthesia agents and muscle relaxants can cause vasodilation, impacting respiratory response. Plus, the patient's positioning on the operating table and the exposure of the abdominal cavity can affect thoracic compliance, potentially impacting respiratory effort and function. And what about the respiratory changes during closure? Closing the abdomen leads to reperfusion of previously ischemic organs, releasing metabolic byproducts into the bloodstream. This can affect pH and contribute to systemic acidosis. Surgical manipulation also triggers an inflammatory response, impacting lung compliance, respiratory function, and systemic inflammation. Postoperative pain and opioid administration can again lead to respiratory depression, affecting respiratory rate and increasing carbon dioxide levels. Achieving cardiovascular stability is crucial for maintaining optimal respiratory function and overall patient well-being. So there you have it, abdominal surgery from an anesthesia perspective. The interplay of hemodynamic and respiratory changes during these procedures is a complex dance that anesthesiologists must carefully orchestrate for the benefit of their patients. Thank you for joining us on this episode of Optimal Anesthesia. We hope this information has been valuable to you, whether you're a healthcare professional or simply curious about the world of surgery and anesthesia. Stay tuned for more in-depth discussions on critical medical topics in the future. Until next time, signing off.